Welcome back, Richard. Happy September. It's good to see you.
Yeah, it's September, huh? Man, we're gonna fall in. Well, it's hurricane season here in Florida, but even more than that, we're about ready to enter the holiday season again.
We are, and it's yeah. There's a lot coming up still for the rest of this year, just the last quarter. But before we get to all of that, September, we are into September. This is the first weekend of September, and September has been designated as Suicide Awareness and Prevention Month.
Right.
And so we're going to talk a little bit about some of that, and and some of the leading causes or some of the related factors associated with suicide, and over the course of this month, just to help increase awareness and hopefully increase prevention.
Yeah, we didn't want to spend too much time on suicide, only because it's a complex topic, and we've discussed it a little before, but it is a good time to pause and think about the numbers of people, not only who are committing suicide, which is about 45,000 people a year, at least in 2020. But also the number of people who've thought about it. I mean, 45,000 have actually committed suicide, but over 12 million have seriously thought about suicide.
Right.
Which is, I mean, that starts to give you some perspective. I mean, a lot of people are thinking about it. 3 million, a little over 3 million have planned a suicide attempt. So we're moving a little bit more to serious.
Right.
And but a little over 1 million have attempted suicide.
Right.
And in two age groups, because different age groups have different suicide rates. So for the age groups from 10 to 14 and 25 to 34, suicide is the second leading cause of death in both of those age groups.
Right.
So we're talking about teenagers, particularly young teenagers, which is something you and I have talked about, that the most difficult adolescent years are the early adolescent years, especially middle school.
Right.
So we're not surprised to see that from ages 10 to 14, the onset of puberty brings a number of changes. And then the other group is 25 to 34. And that's the second thing. Generally pretty healthy. People in that age group typically don't go to doctors. Many don't even have a primary care provider. So it's not surprising that suicide would be the second leading cause. The leading cause of death for both groups is accidents,
right?
Especially automobile accidents.
Right.
But suicide is second in these two age groups. But regardless of how many, every one of them is a tragedy. For families left behind and for loved ones left behind, each is a tragedy. So significant, impressive, disturbing numbers.
Yeah.
But certainly each is a tragedy in its own right.
Absolutely, and I think that we would not be doing justice to mention that there are other groups that where the rates are significantly higher. Those in the LGBTQ community are at a significant elevated risk for suicidal ideation, and all of these factors.
Right.
And
veterans is another very high risk group.
Right. So we know that there are individuals who are at increased risk, and we know that that there's a lot of different risk factors, but one of the primary risk factors, and one of the big risk factors, and the one that we're going to talk about today, is depression.
Yeah, because many times people ask us, what are is my child at risk, or is my partner at risk? How serious is this? And one of the things you have to talk about is depression, because depression is one of the leading causes, one of the leading risk factors. I don't like to use the word cause, but certainly one of the leading risk factors when it comes to suicide.
Right. And that certainly isn't to say that every person with depression is going to even have thoughts of suicide.
Right.
That's not the case. And let's not forget that a lot of people who have thought about suicide and even attempted suicide aren't depressed necessarily.
Exactly.
Um,
Right. Yeah.
So, they aren't, there isn't that causal relationship, as you just said, but there is this relationship, and depression is a key risk factor. Now, there are other psychiatric
Right.
disorders, especially things like bipolar disorder,
Mhm.
and like psychotic disorders, but certainly substance abuse is a leading factor in chronic pain. And again, there's just lots of other
Right.
factors and lots of other um, just pieces that get put into this puzzle that we're trying to put together to understand suicide and suicidal ideation a little bit more.
Hmm. Right. So when we talk about what depression is, there's if you think about this, depression can be have a small d as depression,
Mhm.
which is a descriptive term, or it can be a major case D, which would be the medical diagnosis. So there's the word is used in two very different ways. And so when you talk about depression with a small d, we're talking about this feeling and this common language that people use. It's not precise language,
Right.
but the diagnosis is precise. So we always want to make that distinction between, are you just talking about a descriptive term, or are you talking about a diagnosis?
And from a, from our clinical perspective, and we've talked about this many times, just with you and I talking, Richard, that people will come in and they'll describe these things, and you might say, you sound like you've been feeling a little depressed. Oh
Right.
no, I'm not depressed. I'm not. No, that's a lowercase d.
Right.
Depressed means that your mood is just dipped. It's just down
Hmm.
a little bit. Maybe you're not
Right.
feeling as motivated or as driven as you once did. Um,
Hmm.
it's not diagnostic necessarily. It's just,
Right.
and we all go through those times. We all
Right.
have those experiences where you just feel a little down, and sometimes you just wake up that way. It doesn't not necessarily mean that anything happened.
Right, exactly. So we're using this term two different ways. Now, depression, here's the other thing about depression. It can appear out of nowhere. Just
Right.
you get up one day and suddenly the world is different and you feel differently. Or it can be a response to some loss or some event in your life. Many people, we talk about veterans. We certainly have a better knowledge of why a veteran would develop depression, or then we understand that group, but we understand marginalized groups like LGBT, or some racial and ethnic groups. So it can appear out of nowhere, or it can be a response to something in your life. Now, the other thing about depression, and I like the distinction that this particular person makes, said depression comes in many forms. And I like that because the primary diagnosis in DSM is major depressive disorder.
Right.
But there are four or five other conditions.
Right.
And in those conditions, depression is a component of these conditions. For example, bipolar disorder.
Right.
Okay. It's not, it's different from major depressive disorder because you have the manic phase, or seasonal affective disorder.
Right.
So you have depression, but it's a seasonal. So depression is a component of many disorders. But when we talk about a diagnosis of depression, um, we're talking about MDD,
Right, right.
um,
And that's MDD is major depressive disorder.
major depressive
Um,
disorder.
yeah, and it's there's a number of other conditions. If you the way that our diagnostic manual is set up, there's a category called depressive
Right.
disorders. There are a number of disorders listed in there, and
Mhm.
certainly major depressive disorder is the most common, but
Right.
there are others as well,
Mhm.
and we will talk about some of those others in weeks to come.
Right.
um, but the the other thing that we have to remember with depression is that it is pretty common.
Right.
um, it has an influence on not just our psychological, our mental health, but also our physical health.
Right.
For
Mhm.
those of you who remember back in the day when watched regular TV and there were regular commercials that were on all the time, when the medication Cymbalta came out,
Yeah.
and we'll talk about medications in just a minute. When Cymbalta came out, it was really pushing the idea that Cymbalta helped treat the physical pain,
Right.
discomfort associated with depression.
Right.
So not only did it help with depression, but it helped with the physiological discomfort in your body that you feel as a result of this mood disorder. So so it is well known that it affects your entire body.
Right. And the other thing that's important to keep in mind about depression is that it negatively affects how you feel,
Mhm.
how you think, and how you act.
Right.
The reason this is important is because when we get to what do we do about depression, we're going to address most treatment programs address all three of those things in one way or another: how you feel, how you think, and how you act. So
Right.
when we get to treatments, we'll think, okay, how I think, how do I think, and how's that related to my depression? That becomes part of the treatment program. So remember, when we talk about depression, we're talking about how you feel, how you think, and how you act.
Absolutely.
Okay.
Absolutely. So when a person is going to make a diagnosis
Right.
of major depressive disorder, there are a few things that we look at. And certainly everybody recognizes there's a that you feel sad or you feel down. And but that's not necessarily the case. In fact, I had a patient recently who didn't necessarily feel sad, um, but they just didn't necessarily feel anything.
Right.
Um,
Right. Right.
and so one when you look at the diagnostic criteria, sometimes it can
Mhm.
appear complicated, but one of the first things you have to decide is if one of two symptoms are present, and one is a persistent sadness, or down mood, that and for depression, the DSM loves this phrase: most of the day, nearly every day.
Right.
um, and so you have this persistent sadness or down mood, most of the day, nearly every day. Or there has to be this thing that we call anhedonia, or a
Yeah.
diminished interest in almost all activities.
Right.
Again, most of the day, nearly every day. And this
Mhm.
idea of anhedonia is really important because that's when we have this experience of, you know, things that we really enjoy doing, we just don't feel like doing anymore.
Mhm.
We have lots of opportunities perhaps to do these enjoyable tasks, but we just don't have the energy to get up
Right.
and do them. Um, so one of those two have to be present. Now there's other symptoms as well, but
Right.
one of those two have to be present.
Right. But these are every day. We're talking about you're like this every day. And we're going to talk about these distinctions in a minute.
Yeah,
But I think the thing to keep in mind is we're talking about something that affects you most of every day.
right.
And it occurs day after day after day after day. It doesn't come and go. Okay.
Mhm.
It's constant. And you're right. The anhedonia is you just don't have any motivation, no joy,
Right,
there's no no incentive to do anything. You're
right,
just flat all the time. Now, there are a lot of other things that go on with depression, such as loss of energy and loss of appetite and reduced thinking and all that. But there are these criteria. But
mhm,
you're right. There are the two main criteria have to be met. And
right,
if you don't meet those two, and this is going to become absolutely critical when we talk about treatment,
right.
we have to make absolutely certain that we're getting an accurate diagnosis. So these criteria are really, really important because we have to get the diagnosis right if we're going to get the right treatment.
Absolutely. And the reason that they use this most of the day, nearly every day terminology is because um, sometimes we've talked before about the difference between mood and emotions and feelings and some of
And
these different
feelings,
things.
right?
And so sometimes, mood is sort of this underlying undercurrent. It's the undertow in the ocean, for those of you who
Right.
live near the ocean. Whereas your emotions and feelings, those are the waves on top. And so remember that
Right.
the undertow could be pulling you out to the ocean while the waves are moving so they can be different. They can flow in different directions.
Right.
But sometimes your mood can be very depressed, but if your family decides to go to Disney or go to a big theme park, you may have a decent day. You may not feel too terribly down that day because something new and something exciting is happening. But sure enough, what will happen is most likely the next day, that mood goes right back and you're right back where you were. And so it doesn't have to happen 24 hours a day, every single day during the episode, but it's just certainly most of the time, almost
Most of the day,
most of the
nearly every day, right?
right,
Most of the day, nearly every day, right?
right. And there has to be some impairment in functioning. We talk about that a lot
Yeah,
on this podcast, because that's something that a lot of people really don't pay a lot of attention to. But there has to be a significant distress, significant impairment in functioning before you make this diagnosis. Because again, we all feel sad sometimes,
right,
but how is it influencing your life? Is it limiting you in any way? Is it preventing you from doing something? How is it affecting your life?
right.
So one of the things that we talked about a moment ago, and maybe what we just need to tease apart a little bit more, is that depression is not sadness.
Right.
Sadness and depression are two different things. Now, depression is sort of the higher level, if you will, of sadness, but they're not necessarily the same exact thing.
That's right. Yeah. Yeah. Sadness is a normal emotional response to it. And it's triggered by a specific event. Something happens, you forget to pay a bill, or you get a traffic ticket, or, somebody dies, or your pet dies. Something triggers this feeling that you have. With depression, you don't need a trigger necessarily. Now you might, but like certainly going into a war zone would be a trigger. But with depression, no trigger is needed, and you feel sad about everything. You don't feel sad about in sadness, there's a specific thing that you feel sad about. With depression, you're sad about everything.
Right. Right. The other difference is just really the duration.
Right.
Sadness usually lasts a couple of days, maybe, but you can still enjoy other things, but it just lasts a couple of days. Whereas depression, diagnostically, it has to last at least 2 weeks.
Right.
It's not a depressive episode unless it lasts at least 2 weeks.
Right.
So the duration is pretty different between the two.
Right. And with sadness, you might have sadness again about a specific things, but you're enjoying other things.
Right.
With depression, you don't enjoy anything.
Right.
Okay. And so it's the same with how you're feeling about things, because with sadness, even with a major loss, you can still sleep, you're still motivated to do some things, you're still sort of eating. With depression, these normal sleep and eating and work path, they're all disrupted. Okay.
Right.
Everything gets so that's when you talk about impairment, that's where impairment comes in, because with sadness, you're still doing most of the other things you normally did. With
Right.
depression, everything stops.
Right. Another distinction is that, with sadness, you have these feelings of regret or remorse or grief or something. But with depression, and for those of you who've ever experienced a depressive episode, you know what it means to this sense of worthlessness, of, you have these self-deprecating, self-diminishing negative thoughts
Right.
that are again, can be very impairing, because just your self-image, the way that you see yourself and you see your worth, significantly decreases, and affects the way that you function.
And that leads to the last difference, which is self-harm and suicide. People who experience an episode and they become sad,
Right.
they're not inclined to self-harm and suicide. But with depression, frequently individuals who are depressed have thoughts, almost obsessive thoughts, about self-harm and death, and even planning their own deaths. Okay?
Right.
So these feelings with depression are so profound that you have a higher incidence of thinking about self-harm.
Right. Absolutely. So when we make the diagnosis of depression, one of the things we have to do is gather a good history. And usually that's through a good clinical interview to differentiate depression from some of these other things. Sometimes people have persistent sadness, and they're just sad a little bit longer than you would expect. Perhaps it's because the loss or the triggering triggering event is more significant than the person has experienced before or something, and they just don't have the skills. One of the, and I know that we've talked about this before too, it's really difficult for somebody if they've reached adolescence or even early adulthood, for example, and they've never experienced a loss before, and then suddenly there's a major loss in their life.
Right.
They just don't have the skills to know how to treat it or to respond to it, and so it hits them a little bit harder than it might have otherwise, and so they struggle with it. And so you have to have this really good history and clinical interview so that you can differentiate between some of these different things.
That's right, because there's a huge difference if a person comes in and can't do anything, or they can't even come in, they can't get out of it, they're so depressed, versus a person who comes in still going to work, still doing everything, but they just don't feel, they're just flat. They have no joy. Okay, that's different from the person who's completely impaired by their depression. So that's why you do the clinical interview and take this history, because you want to understand, what am I dealing with here? What is this person dealing with? And then in addition to the interview, there are some tests you can do. Normally it's self-ratings. You ask the people to rate themselves. There's one called the Beck Depression Inventory. It's a short form that a person can fill out. There are other larger inventories like the MMPI and some other assessments that you can do with dozens or even hundreds of questions. And you gather all this information together, and it gives you an additional insight into how this person is really feeling.
Yeah, and obviously the limitation is that is self-report. So the person is saying this for themselves, and you have to be careful. Is the person, sometimes when we're sad or depressed, we tend to overestimate or exaggerate sometimes those symptoms, and sometimes when we have other mental health conditions, we have a tendency to do that. So, it's hard to use. You can't just use a test by itself. How many times do we talk about that? You can't use just the results of a test itself to make a diagnosis. These are clinical diagnoses, and so it really requires those clinical skills and understanding of the condition. So
there is no test that you can give that said, well, this person has, because even if they score high on the test, they still may not get the diagnosis based on the clinical, based on their history and their responses in the interview.
Absolutely. That's why, that's why there aren't any internet tests that are really good that somebody can take that really gives them valid, confident, absolute information, because it's just too difficult to do that with just questionnaires. So, but once you get the diagnosis, then of course we get into treatment, and this is where you start seeing some really big challenges in the research literature. We've talked before on the podcast about some of the variability, we'll say, in what the research says about the efficacy of medication, of the antidepressants. A lot of people respond well to these medications, but it takes time. It takes time for them to be effective and for you to see the effect, the influence of them.
Right. Yeah. Very high numbers, very high efficacy numbers. 80 to 90% of people with major depressive disorder do have a reasonably positive response to medications.
I'm going to jump in right there, because the words that you said need to be emphasized. 80 to 90% of those people with depression positively respond to the medication. The problem is that a lot of times these medications are prescribed to people who don't really have depression. They might have some of those other diagnoses that include depressive episodes or depressive symptoms, but if they don't have major depressive disorder, these medications may not be effective or may not be consistently effective for them. And so that terminology that you used was brilliant, because that is the key factor. They have to really have major depressive disorder for the medication to be effective.
Right. And we're going to talk in a minute about how these medications are related to increased risk of suicide.
Right.
And that's why diagnosis is absolutely essential, because in people who don't have the diagnosis, these medications can actually create problems,
Hmm.
okay, rather than solve them.
Right.
So
Right.
yeah, diagnosis is absolutely, that's sort of a shout out to Dr. Silver,
Yeah.
who always stressed you got to get the diagnosis right.
Absolutely. So there's a lot of classes of medications that fall within the broad category of antidepressants. There's things like the SSRIs, which are selective serotonin reuptake inhibitors, SSNIs, selective serotonin and norepinephrine inhibitors, reuptake inhibitors. Then you have these atypical ones, like I mentioned. I mentioned Cymbalta, that's a SSNI, but there's also Wellbutrin that falls into the category of atypicals. And then there's this old school class called tricyclic antidepressants that really aren't used as much for depression per se. Some of the tricyclics are used for, interestingly enough, some of the tricyclics now are used for stomach problems, gastrointestinal issues, and others are used for sleep problems because they have a side effect of causing a lot of drowsiness. So yeah, there's a lot of different classes and groups of medications known as antidepressants.
And that's why, again, diagnosis is so important, because what we're asking the medications to do is to reduce our symptoms,
right,
so that we can do all the other things that we have to do. Remember, at the beginning of the podcast, we talk about how you think, how you feel, and how you act. The problem with depression is you don't want to do any of those things.
Mm-hmm.
But if we can reduce the symptoms, then we can start the person feeling differently, acting differently, and thinking differently.
Right.
And that's the combination. Sort of best practice combination is medication plus what is called psychotherapy. It's all the other things you need to do. So the medications they're not going to cure anything.
Right.
They're simply going to reduce the symptoms.
Right. Yeah. Now, you mentioned a moment ago about this risk that one has to be mindful of an increased risk for suicidal ideation.
Right.
And this all started in the early 90s, where there was a case report documenting increased risk of suicidal ideation in a group of individuals who were taking SSRIs. They, some research was done, and in 91, the FDA said that there were was not an association, but then fast forward about 10 years later, in the early 2000s, 2004, there was this association found between Paxil and an increased risk for suicide. And so at that time, it was issued that a black box warning needed to be put on antidepressant medications that said anyone under the age of 18, we had to be mindful that there was an increased risk for suicidal ideation.
Berney, explain to people exactly what a black box warning is.
Yeah. It's what is referred to as if you think about that box on this, this is a horrible example. I don't know why it's the first one that jumped in my mind, but if you look at the side of a cigarette box, a cigarette, there's a square box that is a black outline. It talks about what the Surgeon General says, that smoking tobacco is increased risk for blah blah blah.
And you see that on alcohol and cigarettes.
Right.
There's a black box warning on cigarettes and alcohol.
Absolutely.
Right.
And so there's a black box warning on these, that there is this risk. Now, I've always struggled. Full disclosure, I've always struggled with this idea of just saying that, well, for some reason, this population, there's an increased risk of suicidal ideation whenever they take antidepressants.
Right.
We don't have time to go into it right now, though I would really love to. We don't have time to go into it right now, but I think that the real problem that we're dealing with is, we started out this podcast saying that depression is a symptom of a lot of other conditions.
Right.
Well, if you're talking about a 16-year-old who experiences depression,
right,
we don't know if that depression that they're experiencing at that time is because they have major depressive disorder, which it may look at that time, or if it's just the first episode of something that's much more significant that's going to emerge later as they age.
Right. And right.
They may still have that more complicated condition, and we're only seeing the depression at the age of 16, but we don't know that until it fully.
Yeah, and it's not surprising that the black box warning would be issued up to age 18. That's those very difficult teenage years. So
Right.
am I dealing with post-pubertal feelings, emotions, or am I dealing with depression? And it's quite possible that
Am I
the
dealing with depression, or am I dealing with the first depressive episode of bipolar disorder?
that exactly.
We don't
Yeah,
know.
that's right.
So a couple of years later, in 2006, the black box warning was extended up to age 26, which for those of us who understand neurobiology, that makes sense because the brain is still developing until through
Right.
the mid 20s, and so they're just sort of trying to encompass the entire developmental phase, neurodevelopmental phase, to get us up to the mid 20s. But it's just important to know that the black box warning is there, and that it is important to be mindful of this risk, and that we watch for any increase in those kinds of problems in people taking antidepressants.
Yeah, and I think how we talk about this, we have to be very careful about the language that we use because it's very easy to say, well, antidepressants are there, it increases your risk of suicide. Well, not really. I mean, that's really not how that should be worded.
Right.
What should be said is that we know that the use of SSRIs in some individuals
Right.
has led to suicide. We don't know that those individuals had depression
Right.
or should have had the diagnosis. It could be that they didn't. They were given a medication that they shouldn't have been taking.
Mm-hmm.
Okay, and the medication had an effect that led to somebody's suicidal behavior. So we don't. I mean, the literature is still being done on this topic. It's something that would require. You're right. It would require an entire podcast to sort of sort through it. But we also know that the drug manufacturers have faced some pretty significant lawsuits where they're paying, $300 million in punitive damages. And so when you're paying those kind of expenses, yeah, you're probably going to submit to a black box warning. And let's be safe. I mean, let's keep everybody safe. But it's just there is this association. We don't know exactly what or why.
Right. And so all of that leads us to what is really the best practice as it relates to the treatment of depression. And the best practice, and all of the books say this, though this isn't always followed. Best practice is to start with psychotherapy. And it's obvious that psychotherapy helps because you see a psychiatrist every 3 months or so to refill medication. You see your psychotherapist once a week, once every other week or so. So if a person is on an antidepressant and they're seeing a therapist relatively frequently, once a week or once every other week or so, as soon as suicidal ideation comes up, action can be taken. They can come off of that medication as quickly as is safe. And what the research suggests is then that response leading to the increase in suicidal ideation decreases. It starts to go away. So the importance of psychotherapy can't be overstated. Many times people with depression should be in psychotherapy before they even consider medication, because the research suggests that most people in a depressive episode, the depression starts to go away even by itself within 4 to 6 weeks or so.
Mm-hmm.
Well, remember what we said, it takes 4 to 6 weeks or so for the medication to start to be effective anyways.
Right. That's right.
So let's look into therapy first. There's lots of different forms of therapy, but we should look into that therapy first before we jump to medications.
Right. Yeah, just sit and start talking to somebody. What you want to do, remember we talked about how you feel, how you think, how you act.
Yeah.
And for most of these therapies, it's about how you think, about your life, how you think about things. Okay. That's what you've all heard of cognitive behavioral therapy and dialectical behavioral therapy. We have to do CBT. All CBT does is it's a structured way of changing how you think about things.
That's
Okay,
right.
instead of thinking this, okay, you've been thinking about it this way. Let's consider this. Okay, and also most of you have heard the term mindfulness, and
Yeah,
again, being more mindful of
right.
what you're doing, how you're thinking, how you're feeling, how you're responding, is another way to reduce these depressive symptoms, to manage your depression.
Absolutely. Family therapy can be helpful. Many
Sure.
times group therapy can be helpful.
Hmm.
So there's lots of different options when it comes to a psychotherapeutic approach to
Right.
treating depression. And you just need to find, find a good professional that will listen to what's going on and help make the best recommendation for you. And again, many times you can start this before you even, go towards medication.
Hmm.
And that professional can help guide you in that direction if it looks like, it's not really responding very well to what we're doing here. So let's consider consulting with a physician
Right.
that might be able to talk about medication.
And there is no right therapy. There is no best therapy. It's what is going to work for you.
Right.
And for some people, it is cognitive behavioral therapy. And some people, it's better to use family therapy because you're changing the person's environment. And that's really what that person needed,
Right.
because it was the environment that needs to be changed, that can be changed, that would lead to improved outcomes. Or
Absolutely.
you go to group therapy and you see what's good about group therapy. Well, I'm not the only one experiencing these things,
Right.
and I can I can hear how other people have dealt with theirs. So
Mhm.
I'm more informed about what I might do. So it really is a matter of choosing, work with a therapist and choose what works for you.
Absolutely. Absolutely. So if depression seems like something that's affecting you or someone that you love or know, certainly encourage them or encourage yourself, whichever the case may be, to get some of that help. Talk to somebody. There are so many resources available now.
Right.
Even virtual, where you can get some help, at least get some information, and try to move in that direction of healing and helpfulness. So,
Yep.
all right, I think that's it for today. We will be back next week to talk about some other, perhaps some other factors associated with this suicide prevention and awareness month, and we will see you all then.
Good.
So, until next time, stay happy, stay healthy, and forget to be afraid.